We are live.
Good evening, all. Welcome to iFocus Online, the 368th episode, the 35th in the Oculoplasty module. Today, we have with us Dr. Santosh Honavar from Center for Sight, Hyderabad, to drive into our minds the logical approach to a differential diagnosis in a case of proptosis, a clinical algorithm. Over to you, sir.
Thank you, Subha. Good evening. I'll be talking about the differential diagnosis in a case of proptosis. In the last few weeks, I think you have had very elaborate lectures on evaluation of proptosis by Abhijit Kaur and then measurement on a case of proptosis by Chef Ali Chahar. But this is going to be slightly different, but it may overlap the aspects that they have already covered. But this will put everything together in the sense that if you have a patient with proptosis, what should be your thought process and how should you be going ahead with a differential diagnosis once you've seen the patient clinically and possibly seen the imaging, appropriate imaging, which could be either ultrasound B scan, CT scan, or MRI. And this has already been explained to you, I believe. But it's always good to know whenever you are thinking of differential diagnosis, the progression, the second P, which has two components. One is onset and second is progression itself. Onset is sudden when it is in terms of hours, generally infections. Acute in terms of days could be a rapidly growing neoplasia, round cell tumor especially, or a tumor that has undergone necrosis, or even infection and very aggressive inflammation. Subacute in terms of weeks could be either infection, which is of chronic etiology such as tuberculosis, or it could be neoplasia, or it could even be inflammation. So everything comes as a differential diagnosis in subacute. Chronic, generally benign neoplasia and indolent inflammations. Progression could be catastrophic, which is in terms of few hours, generally infection, especially mucormycosis, such sort of infection, or a patient who has had a subperiosteal abscess now, which is breaking into the orbit, rapid and slow progression. So with this background, you can go ahead with the diagnosis. Now, before I go further, just the terminologies which are already familiar with, I would like to reintroduce this because this will help us differential diagnosis. What about this, Subha? What kind of proptosis is this?
It's the axial proptosis of the
axial
left
proptosis of the left eye with minimal displacement. You can simply call it axial. This is abaxial proptosis. So depending on the amount of proptosis, amount of displacement, you will be able to judge where exactly the tumor could be. For example, this patient has abaxial proptosis with downward displacement. She has about 4.5 millimeter of proptosis with about equal amount of displacement. So where do you expect this tumor to be?
in the superior and the anterior
orbit. Where? Anterior, mid, posterior orbit.
Yeah.
There is no medial displacement or lateral displacement. You expect it to be a superior lesion with equal amount of proptosis and equal amount of displacement. You expect the lesion to be somewhere around the equator of the eye, right?
Yeah.
If it were to be more posterior, there would be more proptosis than displacement. If it would be more anterior, there would be more displacement than proptosis. So you'll even know the possible location of the tumor. Of course, whenever there is eyelid sign, this is clear that it is endocrine Enophthalmos thyroid eye disease. What about this? This is called dystopia, right? Whenever there is lack of support to the eye and eye sinks in that direction, that is dystopia. So it may look like proptosis of the other eye, but the term that is to be used whenever there's a displacement of the eye because of lack of support, not because of pressure from the opposite direction. This is dystopia. That's a very clear term. And that is, Ruju, what is this?
Telecanthus hypertelorism.
Hypertelorism. So whenever a patient has hypertelorism, if it is congenital, you don't worry about it. But if it is acquired hypertelorism, that means that there's a midline tumor, right? Midline tumor could be anything. We'll go into the differential diagnosis later. But if there is a clear history and by looking at the pictures, if you see that this is a developing hypertelorism, patient never had it earlier, it's slowly developing, then you should always think in terms of a midline tumor. Now, what about this? This is called
Exorbitism.
exorbitism. So whenever there is a craniofacial anomaly or a shallow orbit, which could be racial, which could even be associated obviously with craniofacial disorders or anomalies of congenital anomalies of the facial skeleton, then craniosynostosis, etc., then that is exorbitism. It looked like pseudoproptosis. Now, what about this? What is the etiology here? Suspected etiology. Which eye is abnormal?
Left.
Left eye is abnormal. So what's wrong with her?
There is lid retraction and also lower lid recession.
Lower lid retraction. So
Okay.
whenever there is a patient who has lower lid retraction, you should always ask for a history of prior squint, especially inferior rectus surgery, recession. That will take the lower lid retractors along. But she never had any of that. And this is how she manifested. And she manifested with proptosis. She was referred as a case of thyroid disease. She has some amount of lower lid retraction in the right eye as well. So what do you suspect here? Do you suspect an orbital mass? It could be there. It could be thyroid disease. But you should always look at the fundus before you send the patient away for imaging. And this patient had myopic fundus changes, and promptly she has a large eye. She has a posterior staphylomas. So a patient who has anisometropia, high myopia unilaterally can look like proptosis, and that's called pseudoproptosis. And these are the two patients who came with lid retraction, unilateral lid retraction, that looked like pseudoproptosis just because the lid is retracted. Without measuring, you'll say that she has mild proptosis, but on measurement, exophthalmometry, you'll not find that there is proptosis. It is pseudoproptosis. And when you correct the lid retraction in both these patients, proptosis seems okay. She never had proptosis, that is pseudoproptosis. So these are the terminologies that I would like you to remember and use it in day-to-day clinical practice. Abhijit must have already told you about palpation, but I would like to straight away go to positional proptosis or patients who have pulsation, thrill, etc. Now, if a patient were to present to you with Enophthalmos like this, right, what all do you suspect?
Orbital wall fractures.
Enophthalmos with orbital mass, enophthalmos without orbital mass. Enophthalmos with downward displacement, enophthalmos without downward displacement. So if you have a patient with enophthalmos with downward displacement of the eye, if a patient gives a history of trauma, then you should think in terms of orbital fold fracture. If a patient were to give a history of chronic sinusitis and ipsilateral headache, then you should think in terms of silent sinus syndrome, where the sinuses implode, right? They collapse, so orbit widens, and generally the maxilla is the one which implodes. So there is downward displacement. So with or without history of trauma, that's clear. Now, if there is a patient who has enophthalmos with an orbital mass, tell me the differential diagnosis of enophthalmos with an orbital mass, unilateral and bilateral.
Unilateral orbital varices.
Okay. So how do you diagnose that?
By Valsalvan bend.
Right. So when you do Valsalva maneuver or position the patient, gravity comes into play and there will be manifest proptosis and also displacement. So depending on the location of the predominant location of the orbital varices, displacement could be anywhere. Orbital varices generally is located more in the inferior orbit. So patient has displacement of the eye up, and also proptosis when the patient does this Valsalva maneuver and bend down. So what are the other examples of patients who have positional proptosis or Valsalva positivity apart from say orbital varices? Do you have any other examples to give? Yeah. Good. You're not.
Sphenoid wing dysplasia.
Okay. So that's seen in
Neurofibromatosis.
neurofibromatosis. Or what else? Is there any other differential diagnosis? Quickly. Meningocele and meningomyelocele, right? Those obviously sphenoid wing dysplasia also causes that. So either it is acquired or congenital. Acquired could be because of a hiatus that is created, either because of a trauma. For example, patient has trauma and there is a orbital roof fracture with meningocele or meningomyelocele, or patient has had a craniofacial surgery and there is some amount of bone resection or trauma following which bone has been resected. So you have created a hiatus, right, between the orbit and the brain, resulting in meningocele and meningomyelocele, meningoencephalocele. So that can cause positional proptosis. So this is a patient who was referred as adenoid cystic carcinoma. Do you believe the diagnosis? Slight amount of downward anterior displacement of the eye with mild proptosis of the right eye. Forget about her throw elevation. She was a dancer. That is her expression, right? So do you think it is adenoid cystic carcinoma? With bone changes, roof missing? Possibly. There is a tumor which is isodense on CT scan, isodense on MRI, located in the superior-temporal orbit, involving or seemingly involving the lacrimal gland with a lot of bone changes. So it could be, but when you do Valsalva maneuver in this patient, you see that the eye is bulging forward and she had a postural proptosis as well. This was dural AV malformation presenting as adenoid cystic carcinoma. It's not untrue that patients who have arteriovenous malformation can also have Valsalva positivity, depending on the venous component therein. And also they can have positional proptosis, but not as severe as the one which has a predominant venous component, that is orbital varices. So both are possible. Now this patient, this is obviously not my video, but borrowed. You can see that there is pulsation. Whenever there's a pulsatile proptosis, you can think of dural cavernous fistula or keratico-cavernous fistula, especially the high flow keratico-cavernous fistula, not the dural cavernous fistula, would cause spontaneous pulsation. So a patient with neurofibroma, as you rightly said, this is called the bare orbit sign. You can see the herniation of the brain. So these are the ones who can also have pulsatile proptosis. So there are many other differential diagnoses for pulsatile proptosis. These are the ones, right? CCF, arteriovenous malformation with an aggressive arterial component, neurofibromatosis, meningo and meningoencephalocele, acquired hiatus because of trauma and surgery. These are the causes for pulsatile proptosis. So now you know what are the causes for positional proptosis, pulsatile proptosis, and also causes for Valsalva positivity. So if you do this very quickly in every patient without even bothering about the differential diagnosis. Now you have a patient proptosis, you don't know what is the etiology, it's not thyroid disease. You have to go ahead and do almost all of this tests as a matter of routine very quickly. You don't have to waste 2 hours doing it, but very quickly in a matter of 30-40 seconds, if you do it, your differential diagnosis will be much better. Now, if you're looking at a patient with proptosis, but before you dilate, you should look at the iris, right, for Lisch nodules. So in a patient who has Lisch nodules already, even if the patient is not a child, adult, and there is axial proptosis, there is a good possibility that the patient may have optic nerve glioma or even optic nerve sheath meningioma or even an orbital neurofibroma. So your examination is never complete unless you have looked at the eye in entirety. This is also one more important pickup. Patient who has oculocutaneous melanocytosis, episcleral melanocytosis, palatal pigmentation, hairline pigmentation can have an orbital lesion. And what is that orbital lesion? Of course, they have a uveal melanoma, but they can also have a primary orbital melanoma, especially if this is associated with what kind of a nevus?
Nevus aorta.
Blue cell nevus, of course. Nevus aorta is fine, but blue cell nevus. Now, periocular changes also help you diagnose a patient. This looks like a battered baby, right? But it is not. This patient has
metastatic neuroblastoma.
But you should first describe it. He has
bilateral raccoon sign, yeah.
Periocular hemorrhage with temporal fossa fullness. Right? So this is metastatic neuroblastoma. Now this is very important because periocular changes obviously will lead you to the differential diagnosis. Now tell me the differential diagnosis for patients who have temporal fossa fullness, children and adults.
Primary neuroendocrine tumor.
Okay.
A granulocytic sarcoma. and
Plasmacytoma.
multiple myeloma. Orbital plasmacytoma as a component of multiple myeloma.
Anything that involves the sphenoid wing in a child, right? And those can be, what you
Eosinophilic
said already, plus
eosinophilic
eosinophilic
granuloma.
granuloma, then
Osteosarcoma.
Osteosarcoma.
osteosarcoma. Right? In an adult, it would be more of benign tumors, such as quickly, sphenoid wing meningioma,
meningioma.
right?
Yeah.
Or malignant tumors such as Ewing sarcoma or metastasis. Generally, bone metastasis is from prostate. So when you look at the eye, you should also look at the temporal fossa, and if it is full ipsilaterally, then you should think of this differential diagnosis. So every point that you note will become very important. Other periocular changes like this, where a patient has yellowish lesions around the orbit, this is important sign. This is
Adult onset xanthogranuloma.
adult onset xanthogranuloma. So these patients will also have moth-eaten appearance of the extraocular muscles. In fact, this is one of the differential diagnoses for non-thyroid enlargement of the extraocular muscles. You should make a list of non-thyroid enlargement of extraocular muscles: single muscle, single orbit, multiple muscles, same orbit, multiple muscles, both orbits. All right. So the lecture cannot be longer than an hour for sure. So I won't be able to go into each of this, but subsequent classes can explore all these possibilities. But basically what I'm trying to tell you is that if you have all these lists with you in your own mind, you don't have to make written lists, then your differential diagnosis will be very easy. At least clearly you tell me one major cause for bilateral enlargement of extraocular muscles, non-thyroid,
Non-specific orbital inflammatory disease like multifocal
non-inflammatory,
myositis.
non-inflammatory.
Low flow dural
Dural cavernous fistula. That's very good. So if it were to be unilateral, you would think of keratoconus fistula. It behaves exactly like thyroid disease, except for the fact that there will not be any lid signs, and there will be episcleral venous congestion. Cranial nerve examination and regional lymph nodes are also important. Now, what are the causes for proptosis with ophthalmoplegia?
orbital apex syndrome.
Yes.
Uh,
Orbital apex syndrome could be, generally it is attributed to inflammation, specific or non-specific, but orbital apex, compression at the orbital apex could also be because of a tumor as such, benign or malignant. Any tumor, benign tumor peeping into the superior orbital fissure, orbital apex can cause that. Fungal granuloma can cause it, tuberculosis can cause it, right? Even fibrous dysplasia can cause orbital apex syndrome. But orbital apex syndrome, the term is used for anything of inflammatory origin. So compression of the orbital apex, either by inflammation or by tumors, then or infections. Then other causes for ophthalmoplegia with proptosis.
Any tumor with cavernous sinus extension.
Okay.
TED.
Okay. TED is not ophthalmoplegia. Ophthalmoplegia is when you can attribute the ocular motility restriction to a particular nerve or a particular set of nerves, isn't it? So if it is global, of course, that is fine. But if it is, why are you missing out on superior orbital fissure and inferior orbital fissure syndrome, which are also inflammatory in origin? Neurolemoma arising from a motor nerve. So we have had cases of third nerve neurolemoma, right? In fact, our MRI specialist would even trace it to a particular branch of the third nerve, and these patients do tend to have ocular motility restriction. And any patient who has a tumor, orbital tumor with intracranial extension. So there are differential diagnoses for proptosis with ophthalmoplegia. No, what about proptosis with extraocular motility restriction? Without any, motility restriction does not fit into any particular nerve lesion, but then he has or she has motility restriction. So what are the differential diagnoses?
Mechanical compression by tumor itself.
Okay.
Hydatid cyst.
Why don't you be more systematic? Infection, myocystis, inflammation, myositis. Congenital could be fibrous hematoma of infancy. You have seen cases, all of this you have seen, right, in the last less than 1 year. ASPS, you haven't seen it, but it's a very rare tumor. What is this? Expand it. Alveolar soft part sarcoma, which arises from an extraocular muscle. Tumors causing mechanical restriction, just because of their location. Tumors with extraocular muscle infiltration, such as lymphoproliferative disorders, and tumors metastasizing to extraocular muscles. So this is a patient with ASPS. It looks like a silent proptosis without any inflammation, etc. Ocular motility was restricted, and you find this tumor right in the superior oblique muscle. So these patients do have ocular motility restriction. May even look like acquired Browns. They may have the tumor in the inferior rectus, any of the extraocular muscles, but this one was in the superior oblique. This was ASPS. This was a patient with cutaneous melanoma metastasizing to the medial rectus muscle with ocular motility restriction. Nobody knew that she had a cutaneous melanoma. She came with congestion in the medial canthus, signs of inflammation, ocular motility restriction, a big muscle. Nobody examined her thigh and the abdomen, and obviously with such a thick extraocular muscle, we wanted to do biopsy. This is what we found, jet black muscle. Then she was examined and we found that she had a cutaneous lesion, which she was hiding for whatever reason. She never gave us the history and nobody even bothered to look at the abdomen. Who would look at the abdomen and thigh in a patient who has ocular motility restriction, you may ask? Well, that may sometimes become relevant, right? So metastasis is a possibility. This was a melanoma metastasizing to the extraocular muscle. Now, this is bilateral breast metastasis. So I was asking you about the causes for enophthalmos with an orbital mass. This is one such. In a patient who has enophthalmos with orbital mass, you should think of serous malignancies metastasizing to the extraocular muscles or around the extraocular muscles, such as serous carcinoma of the stomach and breast as well. So this was a patient with bilateral orbital mass, with bilateral ocular motility restriction, with right eye enophthalmos. You can see she has a much bigger orbital mass in the right side, yet she has enophthalmos. That's because of the desmoplastic activity of serous malignancies. What are the other differential diagnoses that you can give for unilateral or bilateral orbital mass with enophthalmos? We already discussed some. Do you have any more to add? This is published, and you may find my name on it. Even otherwise, what are the other tumors or lesions with desmoplastic activity? Haven't you heard of sclerosing variant of NSOID? Right? Sclerosing variant of NSOID is for sure a cause for orbital mass with enophthalmos, sometimes in the end stage, in the last stage, where it is more of fibrosis than inflammation. Sclerosing variant of tuberculosis, which has been published. Patients who have lipodystrophy, linear scleroderma, and fibrous hematoma of infancy, which you have seen, right? So all these are the causes for enophthalmos with an orbital mass and with or without ocular motility restriction. You should remember this. Now, regional lymph node examination is important. It's evident that patients who have an eyelid lesion or a conjunctival lesion with orbital extension would have regional lymph node metastasis. There's no doubt at all. That's evident. But what if a patient has an orbital mass and regional lymph node involvement? What are the differential diagnoses that you would think of? This is all at the stage of examination, because then you can immediately narrow down your differential diagnosis to a group of diseases or particular set of diseases. What do you think of if a patient has an orbital lesion without a conjunctival or an eyelid lesion, but with regional lymph node involvement? Quickly.
Lymphoma.
Yeah, so lymphoma is fine, but we biopsied a patient yesterday. So patient had parotid and all regional lymph nodes which are hard and lacrimal gland involvement. That is histiocytic disorder. That's called Rosette-Hoffman disease. Sinus histiocytosis with massive lymphadenopathy is the name of Rosette-Hoffman disease, right? So that is one of the reasons. So histiocytic lesions and lymphoproliferative lesions are the ones in which patients have proptosis with regional lymph node involvement. Infections can cause it, IgG4 related disease can cause it, but more important are lymphoproliferative lesions such as lymphoma and histiocytic lesions, and of course, eyelid and conjunctival tumors with orbital extension. So these are the differential diagnoses. Then let's get down to the classic list: congenital, infection, inflammation, traumatic, and neoplastic. If a child were to come to you on the day of birth or a week thereof with an orbital mass like this, what do you think of, Tuju?
Probably orbitopalpebral cyst.
Orbitopalpebral cyst is a good differential diagnosis, especially if the lesion is in the inferior orbit, right? And if the other eye has triangulation sign. Now, what is triangulation sign?
Coning of the
Coning of the cornea. So if the cornea is not spherical and it is coning towards the infranasal side, you expect a uveal coloboma in the same quadrant. So the left eye has relative microphthalmos. It's a slightly smaller eye with some amount of triangulation sign. The right eye has an inferior orbital mass which looks bluish. You expect that it is orbitopalpebral cyst. Okay, so the first thing that you do is aspirate the cyst and see if there is any visual prognosis at all. If there is visual prognosis, then excision of the cyst is warranted if it's not communicating with the eye, or sclerotherapy if it is not communicating with the eye, so that you can give the child the best of visual prognosis. Otherwise, you can attempt cosmesis. Now, the other causes for congenital orbital mass or proptosis is a congenital cystic eye, where there is no orbital mass but just a larger eye, where one of the walls of the eye or the sclera could just be the periosteum. You can see how the lateral wall of the eye is missing, and it is contiguous with the lateral orbital periosteum, and that's a congenital cystic eye. And more importantly, orbital teratoma. This was a child who was brought on the day of birth with a large orbital mass. So teratoma can have a cystic component. As you see here, it is majorly cystic. But just because it is cystic, you can't go into a false sense of security that it is benign. Teratoma can be malignant as well. So the signs that a teratoma can be malignant, clinico-radiological, are intracranial extension. More of solid component indicates a malignant orbital teratoma. Periocular hemorrhage also indicates a malignant teratoma. Bone changes, such as loss of bone in a particular part of the orbit, also indicates that it is malignant teratoma, and the rapidity of growth of the lesion. Okay. So this was again a benign teratoma. This was a young child where there's an inferior orbital mass, but you can see a fully grown molar tooth within it. And then there are other congenital lesions or lesions that appear just after birth or in the early childhood, and that is a clear-cut dermoid. Dermoid does not cause proptosis generally if it is internal angular or external angular. So which sort of dermoid causes proptosis then?
posterior dermoid or dumbbell dermoid.
Right. So posterior dermoid, orbital dermoid mainly are the ones which cause proptosis, not the ones which are located in the anterior orbit. Like patients like this, where you see that the lesion is in the superior orbit, this would cause proptosis and downward displacement. Where the lesion has an osseous component, this is an intraosseous dermoid, this can also cause proptosis with downward displacement. And dumbbell dermoid causes proptosis and displacement, and along with that, does it cause something else?
Pulsatile motion. Like it is
Oscillopsia.
oscillopsia. Yeah.
Masticatory oscillopsia, right? So when a patient chews, there will be transmission of pulsation to the eye, resulting through the temporalis, and the patient may have distortion of vision. Now, this is just a list of cysts in the orbit. While we are talking about dermoid, you should also recollect the other cysts. Orbitopalpebral cyst, teratoma we already covered. Dermoid, then there could be no reason why the patient should not have a simple epithelial cyst or a parasitic cyst, which is cysticercosis, hydatid cyst, implantation cyst, hematinic cyst in a patient who has had trauma, or a small lymphangioma can bleed and remain chronic without much absorption. That forms an hematinic cyst. Optic nerve cyst, either with or without coloboma, right? If there is an optic disc coloboma and there is a optic nerve cyst, that's evident, but some patients don't have an optic disc coloboma but yet have an optic nerve cyst. Cystic degeneration of tumors is common in neurilemoma, optic nerve glioma, pleomorphic adenoma. That is not worrisome, but what is worrisome is the cystic degeneration in patients with rhabdomyosarcoma and adenoid cystic carcinoma. That can actually fool you. In rhabdomyosarcoma, if there is a cystic degeneration, you will think on clinical radiological differential diagnosis that it could be venolymphatic malformation, and there are cases where people have gone ahead and injected bleomycin thinking that it is venolymphatic malformation, right? So you should be very careful with rhabdomyosarcoma with cystic degeneration. Any round cell tumor can have necrosis resulting in cystic degeneration. Adenoid cystic carcinoma can also have cystic degeneration. Now, proptosis that appears just after birth, like capillary hemangioma of infancy, can be present at birth, but generally appears just after birth with a large orbital component can cause proptosis. But the giveaway is that there is generally a cutaneous lesion. So once you have a stigma that is so evident, cutaneous sign, it is sure that it is capillary hemangioma of infancy. This is also a hemangioma of infancy, but not capillary hemangioma of the routine type. That is intraosseous hemangioma. You can see that there is a large lesion within the bone, sphenoid wing, centered in the sphenoid wing with large cavity. This could even be an aneurysmal bone cyst, but this patient underwent a biopsy. That's how we know that it is intraosseous capillary hemangioma. Treatment is, if you want immediate relief, you can curate it, but that will cause a lot of blood loss. So we gave this child intralesional steroids, and over a period of time, it settled down. But to date, the bone remains hypertrophic, and that needs to be kind of remodeled over a period of time. Otherwise, we'll have to do something for cosmesis. Going on to infection, we have bacterial, fungal, and parasitic and viral infection. Grading of the orbital infection, whenever there is a patient who has orbital infection, if it is preseptal, then there is generally no proptosis at all, no ocular motility restriction. But as the patient develops more advanced infections such as orbital cellulitis, or if it starts with orbital cellulitis, patients with, say, paranasal sinus infection need not go through preseptal cellulitis stage at all. They can directly manifest with orbital cellulitis. There you find proptosis, restricted ocular motility, chemosis, conjunctival injection, etc. And a patient has subperiosteal abscess, you find that there is decreased motility, decreased vision, disc edema, and motor and sensory signs of proptosis progress to inflammation. And frank orbital abscess. These are all bacterial. And you can also further have cavernous sinus thrombosis, which can manifest like this with a dilated superior ophthalmic vein without any contrast enhancement. This is a superior ophthalmic vein with contrast enhancement, normal in caliber, dilated superior ophthalmic vein without contrast enhancement, typically cavernous sinus thrombosis. Orbital tuberculosis can also produce orbital mass. Mucormycosis, we know that can produce orbital mass. Aspergillosis in immunocompetent and immunocompromised individuals. This was a patient where there's a well-circumscribed lesion in the inferior orbit. We thought it was a benign lesion, structural lesion, but it turned out to be an immunocompetent individual with orbital aspergillosis. So I'm rushing through this quickly because we'll have classes just on this. But these are the differential diagnoses for patients who have acute or subacute proptosis, who have kind of catastrophic or rapid progression. There you should think of all this. But when you go to parasitic orbital infections, they tend to be chronic or subacute. They never manifest acutely unless a cysticercosis bursts spontaneously or a hydatid cyst bursts spontaneously and causes orbital inflammation. Otherwise, most of these parasitic infections tend to be subacute and chronic. Cysticercosis is a great mimic. When you find a child or an adult with an orbital mass with ocular motility restriction, you should think of myocysticercosis, at least in endemic areas. Generally occurs around one of the extraocular muscles or in the lacrimal gland. As you see here, this patient manifested with a cysticercosis in the palpebral lobe of the lacrimal gland. And the most important diagnostic tool that we have for cysticercosis is a simple ultrasound B scan, where you find a scolex within a cyst and dilatation or thickening of the extraocular muscle, indicating a myocytic component, which is associated with cysticercosis. If you want further evidence, you can, or if you have already gone for a CT scan, you'll also find that there is diffuse myositis, gross thickening of the extraocular muscle, a cyst and a scolex within it. Sometimes you don't find the scolex, especially in a degenerating cyst. You may not be able to find a scolex. This is MRI. So irrespective of which is the imaging modality that you use, you find a vivid scolex which will diagnose cysticercosis. Sometimes absence of a scolex does not preclude the diagnosis of cysticercosis. You can use ultrasound B scan to know the progression of cysticercosis on treatment. When you start these patients on albendazole, the first thing that happens is disappearance of the scolex. Second thing that happens is collapse of the cyst. And the final thing that happens is thickening of the extraocular muscle reverses to normal. This happens with steroids. So whenever you treat these patients, you should always give albendazole along with systemic steroids to take care of the myocytic component. Otherwise, the patient will have relief from cysticercosis, but ocular motility restriction may stay. Now, hydatid cyst, fortunately, has become less common. There are two variants. One of this patient, you can see, manifested like orbital cellulitis because one of her hydatid cysts spontaneously ruptured. Otherwise, she had, going by old photographs, she had this proptosis for a very long time. The only reason why she bothered to present was the acute change that happened over the chronic proptosis, and she had multiloculated hydatid cyst, one of which has ruptured. Right, so there are many variants of hydatid cyst, one of which is multiloculated hydatid cyst, where you find on ultrasound B scan multiple septae like this. The second one is a well circumscribed unilocular hydatid cyst. So this was a patient where there is unilocular hydatid cyst, very nice hydatid cyst with pressure over the optic nerve. You can see this patient has finally undergone orbitotomy for the removal of the cyst. This is a patient, 14-year-old girl with multilocular hydatid cyst. And you can see on CT scan how large the cyst is and multiple compartments within it. And the eye was thiazical, so we did not have to bother much about vision at all. And we could excise this cyst one by one. So many of the cysts could be excised. We sent it in a bottle for the pathologist. So these were the number of cysts that could be excised within one large hydatid family. So this is a multiloculated hydatid cyst. Going to inflammation. Now, thyroid is a form of inflammation. Whenever a patient has eyelid signs suggestive of thyroid disease, you really don't bother about the differential diagnosis. You know that this patient has thyroid disease. He may be euthyroid, hyperthyroid, or hypothyroid. That is for you to sort out. But if a patient has bilateral proptosis, you have to also think of the differential diagnosis without any eyelid signs. Thyroid disease is obvious. Otherwise, you should think of specific or non-specific orbital inflammatory disease. Any inflammatory infiltrative lesions such as lymphoma or leukemia can also be bilateral. Lacrimal gland lymphoma typically tends to be bilateral, although it may be asymmetric. Leukemia is bilateral. Histiocytic lesions are bilateral. Metastatic Wilms and neuroblastoma are bilateral. Midline lesions can cause bilateral proptosis, and CCF is also bilateral. In thyroid eye disease, your diagnosis is based on not just the clinical appearance of the patient, but also the signs that you elicit. Complete evaluation is important. I'm going to rush through this. I'm not going to explain any of the signs because you'll have a class on this. But there are eyelid signs, there are pupillary signs, there are globe signs. So all these signs put together make you diagnose a patient with thyroid eye disease. And of course, you have to look for the activity and severity as well. Now, going on to non-specific orbital inflammation. How does it manifest? Generally, these patients manifest with acute or subacute painful proptosis or ocular motility restriction or bilateral or unilateral orbital mass. They can also present with ocular motility restriction in all directions of gaze if it's apical and loss of vision if it is perineuritic. So manifestations can be very, very diverse. So the only common thing is that they will have pain. Most of them will have pain, either static, dull pain, or pain, dynamic pain on ocular motility. On asking them to move the eye, they will experience pain or they may be static pain. That is one. Second is that it is either acute or subacute. Except for sclerosing variant of non-specific orbital inflammation, all other forms of orbital inflammation are acute or subacute, not chronic. They may linger on to become chronic, but the manifestation onset is acute or subacute, not catastrophic. Now, this is how these patients look on imaging. You find that the inferior rectus is grossly thickened, but what has also happened is the insertion of the extraocular muscle is also thickened. This is unlike thyroid eye disease. If this patient were to have thyroid eye disease, this is how the muscle would have looked. Right? The insertion would be relatively thin, normal, but the middle part of the muscle, middle 3/4 or 2/3 of the muscle would be grossly thickened. That's how thyroid eye disease would look. Whereas in myositis, you find the insertion also being thickened. That's myositis, where the patient would either manifest with unilateral single muscle involvement, unilateral multiple muscle involvement, or bilateral multiple muscle involvement. So all forms of myositis are seen. The next variant of non-specific orbital inflammation is dacryoadenitis, where there is inflammation of the lacrimal gland. There are many variants of dacryoadenitis. This is one such where there could be palpebral lobe involvement, predominantly orbital lobe involvement, predominantly palpebral lobe involvement, or both the palpebral and the orbital lobe can be involved. This is a topic for another class on lacrimal gland lesions. I'll not cover this in detail, but you should have your thought process for these bilateral or unilateral lacrimal gland involvement, palpebral lobe predominantly, orbital lobe predominantly, and both the lobes involvement, with and without
Sherman's.
normal Shermers. So with all this put together, you should be able to diagnose a lacrimal gland tumor. Now, this is a diffuse variant of orbital inflammation where you can see some amount of anterior or episcleral or scleral involvement. Then you have an orbital lesion. Then this child also has extraocular motility restriction and muscle thickness as well. So this is diffuse orbital inflammation. This is typically apical. You can see that the patient has a localized lesion in the orbital apex, right? Tolosa-Hunt syndrome, painful ophthalmoplegia. This is, although this looks as if the optic nerve is straight, and this is not a case of thyroiditis at all. This is a patient with apical form of non-specific orbital inflammation. Then this is a perineuritis. This patient has gross thickening of the optic nerve, almost looks like an optic nerve tumor, but she also has some spillover inflammation of the inferior rectus. That was a giveaway. Otherwise, we could have easily thought that she has, say, optic nerve sheath meningioma, etc., clinico-radiologically. But she has inflammation and she settled on completely with steroids. This was perineuritic lesion. And this patient also had an optociliary shunt vessel. I'm missing the fundus photograph of this patient, but you can be, keep that in mind for differential diagnosis of optic nerve sheath meningioma. So whenever we talk about inflammation, there could be specific inflammation or non-specific inflammation. Pseudotumor is a term that should not be used. So whenever there's a non-specific inflammation, it has to meet this criteria. It should be non-specific, non-infective inflammation without identifiable local or systemic causes, which clearly means that you should have done a good systemic workup to rule out the systemic causes. Locally, wherever it is biopsyable, you should have done a biopsy. I don't expect you to do biopsy for a perineuritic non-specific orbital inflammation. You cannot do biopsy without losing vision. You cannot even do biopsy for a single muscle involvement because the patient will have ocular motility restriction. So unless you have a very high index of suspicion that it could be something else, you should not biopsy a muscle, right? Unless it's atypical so much that you want to biopsy it to rule out any infiltrative lesion. But you don't biopsy a muscle, you don't biopsy a nerve unless you have a strong reason. But otherwise, diffuse NSOID, episcleral scleral lesions, and lacrimal gland lesions are eminently suitable for biopsy, or diffuse orbital lesions. So unless you have done a biopsy, you will not know whether it is a local disease or not, or non-specific or not. So why don't you do a muscle biopsy and optic nerve biopsy? That's because generally these patients don't have any other simulating disease, generally, right? So it is very rare that a patient who has clinical radiological myositis would have a specific etiology for myositis that you cannot diagnose based on your collagen vascular profile or systemic manifestations. So you don't need to biopsy a muscle to establish the diagnosis. Whereas in a patient with lacrimal gland lesion, more often than not, they will have a specific etiology. That is the reason why you should biopsy. They can turn out to be having lymphoproliferative lesions, Sjogren's, etc. So you should biopsy a lacrimal gland lesion, or even IgG4 related disease. This patient has a lacrimal gland lesion. So how do we know that she has IgG4 related disease? Unless we biopsy, do immunohistochemistry, then only you do. Raised IgG4 level in blood really does not help you diagnose because that would not meet the criteria. These patients tend to be very aggressive in their manifestations. They may develop bilateral lesions as you have here. They may have systemic issues. They need aggressive treatment. So it's always a good idea to establish the diagnosis up front by biopsying it. Now, this is a patient, again, you can see that this patient, elderly patient, has more of inflammation, but that did not prevent us from biopsying it, and it turned out to be vaginous granuloma. Now, going on to trauma. Now, what are the causes for proptosis following trauma? since there is not much time, I won't discuss. Basically, I will just enumerate the causes: hematoma, acute or chronic, orbital or subperiosteal. For sure, roof fractures are notorious to produce orbital hematoma, subperiosteal hematoma. Roof fractures can also produce meningocele, foreign body, with or without infection, or granuloma, keratoCavernous fistula, or dural cavernous fistula. Do you have anything more to add? Proptosis following trauma? That's about it, right? This is a patient with dural cavernous fistula. And finally, neoplastic, tumors of the orbit. Part of this was covered along with ocular oncology, but those who have missed that lecture, very quickly cover the differential diagnosis. This is a list of primary orbital tumors, but in your own territory or geographic location, you should know what are more common in children and in adults and in the elderly. And then once you have that kind of a data, it becomes easier for you to fit in, because each region has a different etiology that manifests with proptosis. The kind of epidemiology that you find in India may be different from what you find in China, may be very different from what you find in, say, Northern Ireland, may be very different from what you find in Canada. So you should be very aware of what is more prevalent in your own geographic location. In India, for example, over 1,000 plus patients biopsy proven, we found that lymphoproliferative vascular secondary and cystic lesions were equally common, followed by neurogenic inflammation, mesenchymal, etc. So if you have this gross list in mind, now we have analyzed pediatric and elderly proptosis as well. So once we publish that data, you will be aware that what is more prevalent in our own location. For the purpose of convenience, this is not, this particular talk will not give you complete information, but it will lead you towards the path of diagnosis in a very simplified manner. Of course, we will have a lot of other lectures that are coming in to fill in the void that this lecture cannot cover. But very clearly, you should look at a child with proptosis, whether the child has axial proptosis or abaxial proptosis. If a child has axial proptosis, silent proptosis, chronic proptosis, without any conjunctival congestion, right, without any sign of inflammation, your primary differential diagnosis or diagnosis should be optic nerve glioma. Then you should look for leash nodule. You look for other stigma of neurofibromatosis. If the child has that, your diagnosis is more or less certain clinically. Then, of course, you should do MRI then. You need not do CT at all here. You can directly go to MRI, because optic nerve glioma is a nerve tumor. And any tumor that involves the nerve or where you have CNS manifestations, MRI is clearly better. So you already know which is your imaging tool. But if a child were to have abaxial proptosis, and if it is subacute or acute, then you should think of rhabdomyosarcoma, leukemia, and primitive neuroectodermal tumor. Having said that, optic nerve glioma can also have abaxial proptosis depending on how it has grown. Sometimes it can produce abaxial proptosis, but that is chronic. Whereas here we are talking about subacute abaxial proptosis. There are conditions which produce chronic abaxial proptosis. Lymphangioma and orbital dermoid are the example. This list is not complete. This list includes only the common ones. But if you know this list, you should be able to diagnose in a routine oculoplasty referral practice about 90% of patients. So obviously, in a general ophthalmology clinical practice, you should be able to diagnose almost 95 to 100% of patients if you simply have this list. I'm not going to be complete with this list only because that will cause a lot of confusion. I can easily add 5-6 more diseases for each of these differential diagnoses, but they're so rare that remembering them is okay, but applying them for day-to-day differential diagnosis will totally confuse you, and you may go to a wrong path in management. So this is what is important for you to remember. This is a child with mild axial proptosis of the left eye, very mild, no sign of neurofibromatosis otherwise, and optic nerve glioma with intracranial extension. Child with bilateral proptosis, I was talking about abaxial proptosis. Here is one. The child is looking up slightly with the left eye, not looking straight. You can see that the left eye is displayed slightly down. That's mainly because this tumor is so large that it has grown in a particular area more than the other, causing some amount of displacement. So bilateral proptosis, chronic bilateral proptosis with or without displacement, I would still consider optic nerve glioma as the differential diagnosis. Now this child has subacute abaxial proptosis. The mass is in the superior orbit. When you look at the superior fornix, you find this fleshy lesion. This is nothing but rhabdomyosarcoma. Well, how do we say it is rhabdomyosarcoma? You cannot say it for sure, but that is definitely one of the differential diagnoses. If this child were to be in Africa and the lesion were to be inferior, then you could think of Burkitt's lymphoma, right? If it were to be an immunocompromised child, then we would think of Kaposi's sarcoma. But in a patient who is non-African Asian, then you should think of rhabdomyosarcoma. Other differential diagnoses could be primitive neuroectodermal tumor and an aggressive lymphoma of viral etiology. This is an inferior orbital mass evolving over a few days to weeks. Again, a rhabdomyosarcoma of the inferior orbit. Rhabdomyosarcoma generally occurs in the superior orbit, but inferior orbit is not immune. Similar child, left eye proptosis, but you can see that there is subconjunctival hemorrhage. She also had rod spots. So all that we did was we didn't even send her for imaging. Once you see a child with proptosis, with subconjunctival hemorrhage, your differential diagnosis, of course, you will think of we know lymphatic malformations with bleed for sure, but that should not fool you. If it is acute, don't jump into a differential diagnosis before you look at the fundus. If you find any rod spots or retinal infiltrates, then you should think of leukemia and don't waste time by sending the child for MRI, etc. All you do is a peripheral blood smear. So as a matter of routine, whenever we have a solid orbital lesion in a child with or without subconjunctival hemorrhage, with or without rod spots, the first investigation that I do before I proceed any further would be a peripheral blood smear. And if a patient is already on steroids, somebody else has already started on steroids, then your peripheral blood smear is going to be negative. Then you can jump to even bone marrow biopsy. That can also be negative if a child has received good dose of steroids. That should not fool you. You should immediately and quickly do an orbital biopsy to confirm that the child has granulocytic sarcoma, even when the child is on steroids. So child with proptosis on steroids is not a contraindication for biopsy. In adults, we have the luxury to wait for 3 weeks for a steroid washout, but round cell tumors in biopsy will yield cellular material, right? So if you have a negative biopsy, you can always wait for 3 weeks and do a repeat biopsy, but you always go through the sequence. Do a peripheral blood smear first. If it is negative, do bone marrow biopsy if you're suspecting granulocytic sarcoma. Then if that is negative, then even if the child is on steroids, you stop steroids on that day, and as soon as the child is fit for GA, go ahead with an orbital biopsy, and you should be able to clinch the diagnosis in favor of granulocytic sarcoma, not to wait for 3 weeks or not to inject bleomycin. One more child with a large orbital mass. This was primitive neuroectodermal tumor. This is orbital venolymphatic malformation or lymphangioma, chronic axial or abaxial proptosis, depending on its location. Displacement of the eye can be there or may not be there. This patient has predominant axial displacement, axial proptosis. She did not have much of displacement, although the lesion is in the superior orbit. That's because of fat atrophy that this lesion causes. Now, this is a patient with inferior orbital lesion, bluish lesion, and you can see multiloculated kind of configuration, orbital venolymphatic malformation. But you should be aware that these patients come with acute proptosis. Sometimes it can be vision threatening, either because of corneal exposure or because of optic nerve compression. But when you find this is a sign that there is bleed. And this is also a sign that there is bleed. So when you find subconjunctival hemorrhage or this kind of bluish discoloration around the orbit periocular, you should suspect that the child has a lymphangioma with bleed. But you should rule out leukemia, granulocytic sarcoma, and rhabdomyosarcoma with bleed, intralesional bleed and cystic degeneration before you jump into inject bleomycin. So if you see a lot of solid component within the lesion, very less of cystic component, and the lesion is solid, not multilobulated, then a biopsy is warranted. So in this patient, actually, you can see that there is a scar here. We did a biopsy. We evacuated a lot of blood, but we did send the material for histopathology It was confirmed that it was venolymphatic malformation. It was a frozen section diagnosis intraoperatively. Then we injected bleomycin and the child did well. So you have to go through the specific path. Never kind of jump to a next level without having ruled out a particular more important or a more damaging disease. Going on to adults with well-circumscribed masses, 4 differential diagnoses I would like to put up: cavernous hemangioma, neurolemoma, neurofibroma, and fibrous histiocytoma. Here again, depending on the shape of the tumor, you can have a differential diagnosis. Cavernous hemangioma is either spherical or spheroid. It may have some kind of a irregular contour. You see that all the time. One part of the tumor grows more than the other in competition, but it is roughly, it fits into this kind of space of a spheroid or a spherical tumor. Whereas neurolemoma has this oblong shape. It has a nerve from which it arises and the tail of the nerve. So in between that, it has this oblong configuration, more ovoid, more oblong than spheroid. Neurofibroma also has a spheroid configuration, and fibrous histiocytoma also has a spheroid configuration. Let's see some examples. This was a cavernous hemangioma of the orbit. Very nice lesion, spheroid, and you can see this yellowish surface here. That is because of fibrous metaplasia. These are difficult to remove because this is nothing but tissue changes around the lesion. So sometimes when you have this kind of adhesion, it's difficult to dissect the lesion out easily. This is again a patient with cavernous hemangioma, again with encapsulation. This is pseudo encapsulation. Because of chronicity of the lesion, there could be tissue changes. This is a absolutely nice cavernous hemangioma. These are surgeon's delight. If a lesion does not have changes on its surface like this, which will make it adhere to the surrounding tissues, then it comes out very well. This is a cavernous hemangioma, again typical. This is neurolemoma. Now, how do you say it is neurolemoma? Well, clinically, radiologically, difficult to say, but it has a oblong appearance. Somebody had done an attempted lateral orbitotomy but could not excise it completely. Now, this is actually an inferior orbital, infraorbital nerve neurolemoma. You can see the nerve that is excised. That's the normal thickness of the nerve, and that particular aspect of the nerve is thickened, right? So this is the nerve that is affected, and the tumor has to be excised along with the nerve, and that is neurofibroma. Clinically, it's very difficult to say, but with MRI, you can guess that it is not cavernous hemangioma, or the MRI, you can be quite sure that it is not cavernous hemangioma because you'll not find flow voids, etc. But they will not be able to tell you whether it is neurofibroma or not on MRI. It did turn out to be neurofibroma in a non-NF1 patient. Nobody will be able to diagnose this clinico-radiologically. You may put it as some structural tumor. It could be neurolemoma, but it was benign fibrous histiocytoma. So it's again a well-circumscribed lesion. Only histopathology will confirm the diagnosis. It could even be alveolar soft part sarcoma in an adult, right? You would never know until you excise it. So the dictum that we follow is if it's a well-circumscribed lesion, which is not affecting any of the critical structures in the orbit, not to do a biopsy, but completely excise it. There is no role for an incisional biopsy unless the lesion is infiltrative or removing it completely will cause functional problems. Then only you want to do an incisional biopsy, otherwise excisional biopsy. Now, axial proptosis in adults. These are the 4 causes: cavernous hemangioma, lymphangioma, which is in the intraconal space, optic nerve glioma can also happen in adults. You saw one patient recently. Optic nerve sheath meningioma. I'm telling you one patient recently only for you to recollect that you have seen this patient just the last week so that you don't forget, right? Yeah, you tick off the list. You might have a long list of patients that you want to see, but these are the ones which are there. It's not theoretical at all. You have seen them, right? These are all there. Optic nerve sheath meningioma. So these are the patients who have axial proptosis as an adult. Repeating cavernous hemangioma, repeating lymphangioma, both with axial proptosis, lymphangioma with bleed, and that is
Optociliary shunt vessel with the
optociliary shunt vessel. So if a patient presents to you with what looks like cataract but also has relative afferent pupillary defect, when you peep into the fundus, you find optociliary shunts with pale disc edema or manifest disc edema or optic atrophy. Any of these could be there depending on the chronicity of the lesion and how it has impacted the optic nerve. You think of optic nerve sheath meningioma. All of them may not follow the Calcutta sign or the tram track sign. They may have different variations. This was calcification is the one which leads to that sign, but this patient did not have any at all, no calcification. So this was optic nerve sheath meningioma. Now, adults with abaxial proptosis, these are the differential diagnosis. Four important. I've only given four important differential diagnosis. Rest of these I have put it as other structural tumors for you to simply remember. iFocus is mainly for postgraduate students, so I keep it very, very simple. Lymphoproliferative lesions come on the top of list. Most important is this. Then comes neurilemoma, then lacrimal gland tumor. This is very easy to diagnose because all these patients will have displacement of the eye downwards and inwards. Neurilemoma, if it is from the supraorbital nerve, most common, eyeball will be displaced, bang down. If it is infraorbital nerve, it will be displaced up. Lymphoproliferative lesion, depending on the location of the lesion, it will be displaced. Other structural lesions, well, of course, it depends which structure is affected. This is B-cell lymphoma. So you find that it is an isodense or isointense lesion molding around the eyeball. That's what it is. And when you look at the fornix, you might find a fleshy pink or a salmon pink lesion in the superior fornix. So if you haven't done imaging already, and if you find this in the conjunctiva, then you're sure that it is a lymphoproliferative lesion. You don't know whether it is lymphoma, benign reactive lymphoid hyperplasia, or atypical lymphoid hyperplasia for sure, unless you biopsy it, but you know that it is a lymphoproliferative lesion, and that should be your thought process. You should look at the entire ocular surface in any case of proptosis. Neurilemoma causing displacement, infraorbital nerve. Neurilemoma, you can see that it is from the infraorbital nerve causing upward displacement, and that is the tumor excised along with the nerve. Neurilemoma from the supraorbital nerve, you can see mild downward displacement. You can see an oblong tumor with nerve on both the sides being intact. Going on to lacrimal gland tumors, as I said, lacrimal gland tumors cause many things, one of which is dry eye. If a patient has low Schirmer's, then you have a set of differential diagnosis, especially non-specific orbital inflammation and malignancies lead to low Schirmer's, whereas benign lesions will have normal Schirmer's. This is classic textbook. 50% are epithelial and 50% are non-epithelial. Then you can go into the diagnostic tree: specific orbital inflammations, non-specific orbital inflammation, and lymphoproliferative lesions. In epithelial, textbook and examiners expect that 50% are said to be benign, 50% are malignant, and 50% of the malignant are adenocystic carcinoma. But in real life, these numbers vary a lot. But this is for you to say in the exam. Now, pleomorphic adenoma typically presents with a chronic mass with abaxial proptosis. The lesion is located in the supratemporal orbit, and it causes downward and medial displacement of the eye. You may find bone changes because of chronicity, not always common. And it is said that if a lesion crosses the midline, you think of a malignant lesion. That is true, but pleomorphic adenoma, because of its size, can also cross the midline. This is also a case of pleomorphic adenoma. You can see this S-shaped deformity of the lid, indicating that the palpebral lobe is also involved. So whenever there's a S-shaped deformity, either the palpebral lobe is involved directly or indirectly. It is prolapse that can also cause S-shaped deformity. This was an orbital lobe pleomorphic adenoma causing displacement of the palpebral lobe down that caused S-shaped deformity. So S-shaped deformity of the eyelid does not mean that it is dacryoadenitis. It could be anything else. In this case, it was a pleomorphic adenoma with displacement of the palpebral lobe down that caused the S-shaped deformity. S-shaped deformity here again, with a young girl, you can think it is dacryoadenitis, isn't it? But the lesion had crossed the midline. We thought it was something else. She also had abnormal sensations in the supraorbital nerve location, and she had adenocystic carcinoma. Downward displacement with bone destruction, adenocystic carcinoma crossed the midline. So adenocystic carcinoma is a fairly common tumor of the lacrimal gland. Last part is about triradiate lesions. Whenever a patient has a sphenoid wing lesion, there would be involvement of the orbit, temporal fossa, and also intracranial extension. So these are the examples of triradiate lesions. I have given 5 of these here. Most common is sphenoid wing meningioma. Then everything else is less common. Eosinophilic granuloma is very uncommon. Osteosarcoma is very uncommon. Ewing's is also uncommon. Metastasis depends on where you practice, can be common or uncommon. But the most important diagnosis for a unilateral triradiate lesion is sphenoid wing meningioma, especially if you are looking at an adult. If you're looking at a child with triradiate lesion, we already discussed that it is metastatic, either Wilms or neuroblastoma, depending on whether the child has periocular hemorrhage or not. We already discussed the differential diagnosis for a triradiate lesion in a child. Now, these are for the adults. This is typical sphenoid wing meningioma. Sphenoid wing, epicenter, intracranial, temporal fossa, and orbital extension. That is why you call it a triradiate lesion. Eosinophilic granuloma, again with the same components. Osteosarcoma, second malignant neoplasm in a child with retinoblastoma, again involves the sphenoid wing, causes prominence of the temporal fossa. So any child with retinoblastoma who has come for a long follow-up, I always keep looking not at the eye but at the temporal fossa. And also for proptosis. Even if the child has been enucleated and there is a prosthetic eye, if the prosthetic eye displaces downwards, or if there is poor fitting of the prosthetic eye despite the socket looking okay, then you should think of osteosarcoma developing in the roof of the orbit, especially if the child has received radiation or if a child has bilateral heritable retinoblastoma. Ewing sarcoma is one such example. This young lady has Ewing sarcoma of the sphenoid wing. And this is a patient where the diagnosis was fairly clear because he had an old history of multiple myeloma, nothing ever in the orbit earlier. His X-ray showed punched out lesions, and he had an osteolytic lesion in the sphenoid wing. This was plasmacytoma of the orbit. Whatever plasmacytoma I've seen so far have all been triradiate, except maybe a couple of them in the inferior orbit. All of them had this configuration for some curious reason. This is not reported as such triradiate configuration of a plasmacytoma. Prostate metastasis is also triradiate. Now, hyperosteotic lesions, while we are at prostate metastasis, you find that it is a hyperosteotic lesion. Quickly, a list of differential diagnosis for hyperosteotic orbital lesion. CA prostate metastatic, meningioma is hyperosteotic, tubercular osteomyelitis chronic hyperosteotic, fibrous dysplasia, osteoma, ossifying fibroma, osteosarcoma, chondrosarcoma, chondroma, and Ewing's. All these are hyperosteotic lesions in the orbit. Now, there's one more list for lesions in the orbit which have calcification, and you can figure that out. I couldn't add it. So finally, I think we have run out of time. Yeah. So a good clinical evaluation is the beginning. I think Dr. Abhijit Kaur has very elaborately taught you how to evaluate a case of proptosis. That is the beginning. So once you've done a good clinical evaluation, not forgetting the eye, not forgetting the hairline, not forgetting the palate, not forgetting the temporal fossa, not forgetting the iris, not forgetting the optic disc and the ocular motility, and have taken a very good history, have gone through all the papers that the patient has carried. If a patient carries a large, thick bag, I would remove each paper from every bit of paper that the patient has carried and would look at it very carefully, because there would lie the clue to something that the patient already has undergone or has experienced. So you have to go through the entire clinical history, you have to go through the entire evaluation, look at the old photographs. Patients will carry old photographs on their mobiles. Look at all that to know the temporal sequence of evolution of a particular lesion. Then you would be able to make a differential diagnosis much better than I can, I'm sure, because you would have spent an hour with the patient. I would spend much less time than that, right? So at the end of your clinical evaluation, you should be able to arrive at a differential diagnosis, which should then lead to radiology. And at the end of the MRI or CT scan with the patient will come the next day when you're in the OT, your diagnosis, differential diagnosis should narrow down further, and you should have only 2 or 3 differential diagnoses for me to consider the next day, right? So that is how it should be worked out. So that's what it is. Finally, diagnosis is very important before we take the next step of doing something interventional for the patient or categorizing the patient for conservative treatment or even observation. Thank you so much. If you have any burning questions, I can answer.
Thank you so much, sir, for that elaborate lecture. So in a case of a venolymphatic malformation where we have already done one injection of bleomycin, When do we now, 6 to 8 weeks later, we have seen the patient again. The proptosis has not reasonably resolved or like gone back. And then when do we decide that we have to go ahead with the second dose of bleomycin?
Depends, if you're doing it for cosmesis, then if a patient has achieved reasonable cosmesis, you can stop at one. If you're doing for something functional, recurrent hemorrhages, etc., then you should go ahead and do more. But you should also remember that in macrocystic lymphangioma, the response is much better than microcystic lymphangioma. If you already know that it is microcystic lymphangioma predominantly in the intracorneal space, there is no point giving more and more injections and harm the optic nerve. If it is macrocystic lymphangioma, I would give more, but in microcystic lymphangioma, I'd wait between each injections, I'd wait for 3 months or so. If there is no response, you can add multiple drugs to bleomycin. Bleomycin need not always be the only drug. You can add, for sure, triamcinolone. You can change it to tetracycline. There are a lot of agents that can be injected. You can use Pisibanil if it's an intracorneal lesion. It's just opened up day before yesterday. I got the news that Pisibanil has, they have started supplying it out of Japan again. So there are many options for venolymphatic malformation, just not bleomycin. So you should explore all the opportunities to benefit a patient. Suppose you feel that further injections will harm in terms of, say, optic nerve compression, etc., then you should stop there for a while and then see how the lesion evolves. There is no compulsion to take care of it at 6 weeks, every 6 weeks.
So in a case of, say, atrophic or orthosis bulbi, but not significant in ophthalmos, what are we suspecting? Like in an orbital mass, like how do we go ahead with the
Atrophic or thysical eye with?
thysical eye, but no significant in ophthalmos?
Right. So whenever you have a patient with atrophic eye or thysical eye, most important is if the enophthalmos is disproportionate to phthisis or atrophic or the shrinkage of the eye, you should always rule out an orbital mass, especially if the patient has undergone a retinal surgery earlier, right? Because there could be a lurking intraocular mass which has been missed. It can be missed by anybody because if it's a necrotic melanoma, there is no way a retina specialist or an MRI expert would be able to tell you that it is melanoma. Melanoma can actually become totally liquefied and necrotic. There has been no sign of a solid lesion at all. So they would have done a vitrectomy, think that it is intraocular hemorrhage, vitreous hemorrhage. Fine. And the patient will start growing the tumor back again. Now this time it will go into the orbit. Once it's gone into the orbit and the eye is atrophic, how will you even know? There are situations where these patients have come to my surgical table posted by somebody else that you have to enucleate this atrophic eye for cosmesis, and you find that, well, instead of having little bit of sunken appearance or enophthalmos, the patient actually has proptosis. You know that it is definitely not a routine case of atrophic bulbi or thysical eye. So you have to do imaging before you jump down on to do even evisceration or enucleation. So you should always be aware of the fact in an adult or in a child, irrespective of what is the age, you should realize that there could be a situation where there is an intraocular mass extending into the orbit. There are other causes also. There could be multicavitary involvement. Lymphoma, aggressive lymphoma can be intraocular and extraocular. You have seen one example where patient began with intraocular lymphoma and then there was optic nerve extension. There are many situations like this where patients begin with intraocular lymphoma and finally have an optic nerve extension. And tuberculosis, we saw one patient where there was intraocular tuberculosis with extensive orbital extension. That patient came for enucleation and had proptosis. We did imaging, ocular motility was restricted. He had a mass which was extending right beyond the orbital apex. Currently, the patient is on anti-tubercular treatment and doing fairly well. So there are many examples like that.
Okay. And then in a patient presenting with minimal proptosis but superior displacement, where there is a infraorbital lesion with a conjunctival component or a ocular surface component, presenting with solid chemosis, and then we treated with the topical plus oral steroids for the inflammation component. What is the role of tarsorrhaphy in such cases where we find that there is a significant corneal exposure?
Tarsorrhaphy is just a temporizing measure, but I catch on to the word solid chemosis. Solid chemosis is, unless otherwise proved, is angiosarcoma. Solid chemosis can also be seen in lymphoproliferative lesions. So passive chemosis is something different, but you said solid chemosis. Solid chemosis means infiltrative. Angiosarcoma, lymphoma, aggressive variant of lymphoma, even leukemia can cause solid chemosis. Tarsorrhaphy can always be done, but that's only a temporizing measure. But you have to establish the diagnosis first. For that, biopsies.
Yeah. So in these cases, when we are doing the tarsorrhaphy, won't it increase the intraorbital pressure?
It does, but you have to weigh the consequence of one against the other. Would you mind increasing intraorbital pressure, or would you mind losing the integrity of the eye for perforation? I would definitely want the eye saved. So if you have lost the eye because of perforation, in a situation where there's an orbital mass, you cannot do a graft easily, right?
Yeah.
Even be expulsive hemorrhage. Along with that, the patient may have autoevisceration. So it's always a good idea to preserve the cornea from perforating than worrying about compression.
Yes. Ritika ma'am, any expert comments?
No, I think the topic has been covered extensively, and we have further lectures coming up. So I think we're good to go now.
Ma'am is in a hurry to go for dinner. So
No.
Ruju, any questions from your end? Okay. Before we call it a day, I would like to make a small announcement. We meet next on the 8th of December. The topic being embryology of the orbit, congenital anomalies of the orbit, face and skull affecting the orbit, clinico-radiological diagnosis, classification and management, Dr. Kasturi. Thank you all.
thank you.
Good night.